describes herself as a small town girl trying to make a difference in a big city. She grew up with her mom, who was a registered nurse, and dad, who was a physical therapist. And Emily knew at a young age that she was meant to take care of others, which probably resonates with many of you over here joining this TV summit. Emily bases her practice on a holistic approach and feels it is her duty more than anything to provide information so her patients can make educated decisions for themselves. Takes pride in what she does and has strived to inspire others to do the same throughout her 18 years now working in healthcare. So in terms of training, Emily received her education at UC College, at the UC College of Nursing for BSN back in 2009 and MSN in 2015. And she worked as a nurse in the ICU burn unit over here at UC Medical Center, as well as travel nursing. And once she got her APRN, she found experience in primary care, hospice, and correction, as well as addiction medicine. So Emily, thank you very much for sharing your experiences and wisdom with all of us. And this is, in my view, a very important topic. We will hear about correctional facilities and tuberculosis locally. And I have to mention that in many parts of the world where tuberculosis is much more endemic, correctional facilities tend to act as incubators of the epidemic. And there are many studies these days that show that there is a large proportion of cases that are circulating out in the community that actually have its origins in correctional facilities. That is, of course, a very different setting in some other places. But we will hear more about what happens with tuberculosis screening, prevention, and treatment at our correctional facilities here in the United States. So Emily, thank you very much for joining, and you can take it from here.
Hey, thank you so much for that introduction. Hello, everybody. Once again, my name is Emily Hayes. I'm one of the medical nurse practitioners at the Hamilton County Justice Center. I'm going to figure out how to share my screen quickly. Let's see. Okay. Can you guys still hear me?
Yes.
Yes. All right. Because I lost view of everybody else. But so once again, my name is Emily Hayes. This presentation, I want to first start off by thanking the Hamilton County Health Department for considering me for this summit. It's a privilege to be able to speak and share my knowledge and my experience with more than just the folks that I work with. So I want to thank you again for inviting me to do this. This presentation is Tuberculosis, Correctional Medicine Perspective and Historical Review. I am not a paid partner trying to sell you anything, just trying to give the knowledge that I have. So to start, I know they gave the rundown of my background. Just like to highlight, I come from a medical family. Mom was a registered nurse for over 45 years, and my father worked in physical therapy for many years. And it kind of runs in my bloodstream a little bit to take care of others. I like to highlight my first experience, honestly, with tuberculosis was in 2014. I was a travel nurse working ICU float pool down at Orlando Regional Medical Center and encountered my first active TB case. This gentleman was a young man that had recently immigrated from Thailand. And back then, the only thing that I can remember most in regards to caring for this individual was the common theme of fear that a lot of the healthcare providers, nursing staff, respiratory team, everybody that was working with him. And as a float pool nurse, there's an unspoken rule that the float pool nurse and the traveling nurse kind of gets the assignments that nobody else wanted to take. So I had this individual a lot when I worked in that ICU, and it was a privilege to take care of him. Unfortunately, he did not survive, but it at that time sparked my interest a little bit about tuberculosis. But really, what sparked my interest was attending a Hamilton County summit last year, where there was a panel of 6 infectious disease specialists that spoke. We were on site, and I learned so much, and I was so grateful to be there. And that's what kicked off my most recent, not obsession, but diving deep into knowing more about tuberculosis and realizing that it still is a problem today. A lot of people think that it's a thing of the past, and it definitely is not. So I was very grateful to be there, learn what I learned, and continue to still learn. So I hope that the knowledge I've gained is going to help serve someone else in their practice and how they approach tuberculosis. And this presentation is fun. You're going to get a little bit of fun, a little bit of facts, and a tiny inside view in the fantastic world that is correctional medicine. So off we go. So what we're talking about today is obviously Mycobacterium tuberculosis. I like to say this bacteria goes by the alias of consumption and previously known as phthisis. Phthisis originates from the Greek word meaning wasting syndrome, which is classically known for tuberculosis. You are consumed by this infection. So the fun fact that I like to know about this bacteria in particular is why is it so difficult to treat? It's the waxy cell wall that we see here. I'm not sure which screen I have you guys on. The waxy cell wall is pretty much impenetrable to our immune system. So that is why we can fight it for as long as we can. But actually what happens is our immune system walls it off and encapsulates it. And that is how we move from active tuberculosis to latent tuberculosis infection, oftentimes. Next, fun facts about TB. Didn't realize that it holds the record for the oldest contagious disease. That's fascinating to me. And how long, we'll look at a timeline in the next couple of slides of how long it took to really figure out what this was, what we were dealing with, name it, and then figure out a way to treat it. It's also the only infectious disease that I know of that has a day in its honor. So March 24th is World TB Day, and that's thanks to Dr. Robert Koch's discovery in 1882. And at that time, it's estimated that 1 in 7 people died from TB in the US, which I never realized that the numbers were that high, and this infectious disease was the cause of so many deaths. So that being said, fast forward to nowadays, it is still very relevant. The WHO did a study, and in 2023, over 1 million people died worldwide of this infection. So it's something that we need to be very aware of as providers and all healthcare workers in general. I know that I have been guilty in the past in my training that we kick a lot of things to infectious disease, but being at the front line as primary care, the more I know, the better I am to set infectious disease up for success and for these patients to have positive outcomes. So here is a bit of a timeline, and this slide is really just to show how long it takes before the days of modern medicine to really figure out what's going on. The origin of the bacteria is guesstimated to be over 150 million years old. So this is a force to be reckoned with, if you will. Pott's lesions that are seen when TB infects the spine and deforms the spine has been depicted in Egyptian art. Lots of documentation has been seen many, many years ago in India and in China. They just didn't know what it was. So there is a history, long standing, of this bacteria infecting humanity. It wasn't officially deemed contagious until the 16th century. So following that, the way that they cured it was sanatoriums. So fresh air, isolation, rest, and nutrition was thought to be the cure for tuberculosis. And then following that, it wasn't given a name until the reason why we have World TB Day in 1882 by the microbiologist Dr. Koch. From that time period, not until 1940s, I think specifically 1943, streptomycin was created, which now we were able to treat and cure this infection. Now, this slide, I had really hoped some of our staff was able to also present during this presentation. Unfortunately, they're not able to be here today, but they did give me permission to tell their story. We have a nurse here that her parents had active TB, and she also received INH treatment when she was a child because of this. Now, back then, it was in the early 60s, and her parents were placed in one of these sanatoriums that were built in Kentucky. Now, everybody knows the infamous Waverly Hills Sanatorium that a lot of people do haunted tours and stuff like that on site. But there were actually 5 sanatoriums built in Kentucky based on census information. So her parents were particularly in the one in Paris, Kentucky, and all of them were based on the same blueprints. So the facilities were identical in their look and the way that it was set up on the inside. And some of these pictures, I think, are fascinating so that you can get a look into the past at how they were treating people in Kentucky. Now, back then, from the way that she described it, it sounds like her parents, it was not an option to go into the sanatorium. And unfortunately, at that time, while her parents were in the sanatorium, her and her siblings became wards of the state. So they were taken into foster care and given INH. So parents got out. From what she says and her siblings say, between 6 and 9 months later after they went in. So very difficult time in her life. But I thought that it was interesting and that we should recognize her and give her testimony for seeing the way that we used to treat this disease. Now, fast forward a little bit and let's talk local. So everybody knows this building in downtown Cincinnati, Music Hall. So it's not the building in particular, but the site was the location of a isolation branch of University Hospital in the early 1800s. And I thought it was very sad to find out that in some circles it was called the pest house. So there was a lot of negativity that surrounded the treatment of tuberculosis infections and smallpox infections. Like I said, when I was in Orlando Regional Medical Center, fear was the biggest takeaway in caring for patients with these infectious diseases. And when we know better, we do better. And fear should not be the tone when we're taking care of people with these infections. It's not us against the people with the infection, it's us against the infection itself. So trying to decrease stigma that still comes along with this infection is something that I strive to do, because there's still a lot of shame and misinformation out there in patients that we do find to have latent TB. But we'll talk more about that here in a little bit. I don't know what happened. Are you guys still there?
Yeah, we're still here.
Yes.
What are you seeing on your end?
It wasn't letting me advance my slide. There we go. Okay.
Okay.
We're back on. So some more local history. This is Dunham Hospital, which is located in West Price Hill. This was a big treatment center for originally smallpox and then tuberculosis. So the symbol that you're seeing next to the main picture is the old school symbol for tuberculosis. So I thought it was interesting that that was on the walls for the entry of this hospital. Now, why is it called Dunham Hospital? That is because of this gentleman right here. It's still not letting me. Sorry, folks, for the technical difficulties. Here we go. Dr. Henry Dunham, my kind of guy. So he was the lead researcher and president of the association, and they named the facility in his honor in 1945. So this doctor, when I say my kind of guy, sounds like he was somebody that took a lot of pride in his work and wanted to make sure things were done correctly. So his colleagues have been quoted saying that he took time to read every patient's x-ray that came into the hospital that was named after him. So I find that very honorable. And he was groundbreaking in what he called a fan when he was looking at these radiographs for the presentation of the consolidation in the lung, which he thought was a definitive finding at the time, and to me still is a definitive finding, obviously. So a little bit of a shift for the history, local, and what the infection is. I like to call these peculiar impacts of tuberculosis, because whether or not people realize it, beauty standards were influenced by this infectious disease, which I find a little odd myself, but it still impacts beauty standards to this date. For those that are avid readers and familiar with Lord Byron, he's been quoted saying, "I should like, I think, to die of consumption, because then the women would all say, 'See that poor Byron? How interesting he looks in dying.'" So it was fashionable, which is horrific to me. I mean, this was a disease that was killing the masses, but people based beauty standards off of it in the 18th century. So what they were doing to have the appearance of consumption was they were using belladonna, which is deadly nightshade, toxic, poisonous plant that they were making tinctures of to put in their eyes to make their pupils dilate, and then putting it on their skin of their face to make their cheeks flush. And what they were doing with this, they were trying to imitate the low-grade fever that people with tuberculosis had long-term most often. Avoidance of the sun exposure to look pale on their complexion, which interestingly enough, then the shift came later for the pursuit of the tan because of modern treatment being sun exposure years down the road. The clean shave came about as well. They theorized that beard hair and mustaches were more likely to retain bacteria and cause tuberculosis infections. So clean shave kind of came about. And then a healthier corset. I don't know anyone or any medical provider that would ever say that a corset is healthy, but tuberculosis brought about the idea that the boning corsets that were extremely restrictive might have been contributing to tuberculosis. So they started using more flexible fabric and softer fabric so that there was more expansion of the lungs. And then shorter hemlines of the dresses. It was believed that if your hemline drug across the ground, that you were bringing bacteria and infection into the home. So one of the infamous photos that I found very interesting was this one in particular. If you can see in the dust coming off of her hem, it's written consumption, influenza, germs, microbes, and typhoid fever. So fascinating. Now this slide, I would like to take a moment to honor these people. I'm sure some of them look familiar to individuals, Vivian Leigh and Gone with the Wind, Henry Thoreau, well-renowned and loved author, Doc Holliday, the gunfighter, Tom Fogerty, one of my favorites, and one of the most recent people that I'm aware of who died of tuberculosis. He was in the band Creedence Clearwater Revival. And then Clara Barton, the founder of the American Red Cross. So we're seeing these folks that are from all walks of life, died of different ages, but the common theme that I'd like to point out in this slide, and the unfortunate theme is there's not many people of color mentioned here. Historically speaking, the racial implications of tuberculosis run very deep. So much so that when they were figuring out what this disease was and figuring out ways to treat it, the racist folks believed that TB did not impact people of color, that it was a plight of the master, is what has been quoted in some of the research that I've done. And I think that that's a real shame. So I want to highlight this gentleman here on the bottom row, Mr. Dred Scott. So if you notice, I have put a star by what he did for a living. And I did that because it's according to me. I did not think that it was honoring him by putting that he was a slave. He was sold to an army physician and he traveled around with that army physician. So I'm going to deem him a physician assistant because I'm sure as a physician's hired man, he was helping him in whatever procedures he needed to do and taking care of patients and lugging his equipment around. So I'm deeming him a physician assistant. But this person is very important in the influence and to speak to the social and racial travesties of the history of tuberculosis. So, Mr. Dred Scott, we're going to talk about systemic racism because while this presentation can be fun and lighthearted, talking about beauty standards and the history and the waxy cell walls, I find that it would be a crime to not discuss how, to this day, it still is impacted by systemic racism. So Dred Scott, like I said in the previous slide, technically was a slave for many years who was sold to a army physician, traveled around the nation, the country, and landed in St. Louis when it came time to stop traveling. And when his owner passed away, the wife of the owner was not willing to grant him his freedom, even though they were in a northern state. So he sued for his freedom and for his wife and his children's freedom. Now, this is known as one of the poorest decisions of the Supreme Court, and I can definitely agree with that. The court decided that since he was a slave, that meant he did not have rights and therefore could not be a citizen. So his case was thrown out. Later, it was overturned and he was freed along with his family. He succumbed to tuberculosis about 2 years after that happened. Now, this is important because back then they didn't believe that people of color were infected with tuberculosis, nor were they treated very often. So I found it interesting and glad that it was on his death certificate that he died of tuberculosis. So this was very influential in the Civil War. So a few years later, the Civil War broke out, and the racial implications that he suffered from is part of why later down the road we had the Civil Rights Act. So to give you an inside look at just how poorly people of color were treated back then, I have this quote here from one of the sanatoriums and the decision that they made to not admit Black people because segregation was uneconomical, meaning they didn't want to spend the money to modify the facilities to keep segregation in place. So instead of making modification, they just decided that they weren't going to take care of these folks. And I think that is a real shame. And I think that racism is still very prevalent today in healthcare. And if we don't acknowledge it, we're never going to improve it. So fast forward, Jim Crow laws ended following the Civil Rights Act of 1964. So then there could be no more separate but equal, thus opening treatment centers for African Americans and people of color. How it impacts today. A study done in 2020. I love this quote. Tuberculosis is accurately termed a socially determined disease that reflects economic, racial, ethnic, and health disparities in the United States. I could not have put it better myself. I'm not always the best with words, but this still reigns true today. And in a book that I recommend at the end of this slideshow, there is a quote that the author says that the treatment is where the disease is not, and the disease is where the treatment is not. And that could not be more true. So now we're going to shift gears and talk a little bit about what I do and give you a glimpse into correctional medicine. So this is the Hamilton County Justice Center. This picture was taken downstairs in our lobby. So just another little tidbit of history. Those books there in the display case are old jail records where you can see people's names, the crime they committed, when they were taken into the jail and when they were released. I believe even some have bonds pricing set. So it's kind of fascinating to look back. So our incarcerated population. Who are we working with? Who are we taking care of? Oftentimes it is people with lower socioeconomic status. Frequent history or current substance abuse is very prevalent, especially at our location. Lower literacy rates. There was a study done, it's a little dated, but in 2003, where it was estimated 70% of all incarcerated adults have a reading level below the 4th grade. And while I would like to think that number is a little high, the longer I work here, the more I find that it's accurate. So we're dealing with a population that aren't capable of processing information at a 4th grade reading level, which makes it more difficult to educate folks. A higher incidence of undiagnosed and untreated medical and mental health issues. These are people that are underserved, that have been outcasts of society oftentimes and don't feel safe in the hands of healthcare providers because of past experiences. So they're very untrusting. They're very unwilling to go get checked out and to be evaluated. And if they even have a slight inkling that there's an underlying mental health issue, they want to avoid that being documented at all costs. So a very reluctant population to get treatment. Now, that's not saying all. It's just a general theme that I do see in my day-to-day practice. Now, availability of treatment in incarcerated population. We are kind of the last to get access to things. We're low on the totem pole. So it's, we work with what we have. This is a little bit of a reflection of how delayed we are, especially in the treatment of TB when treatment did become available. And the prevalence, I think that the physicians spoke well in the beginning that we are kind of a hotspot and almost an incubator for active cases because of the reluctancy of testing and treatment and the way people are so closely confined together. I couldn't agree more. A study done recently, 3.6 of newly diagnosed TB cases in the US are individuals that were incarcerated at the time. So when we do capture, hopefully they are here long enough to where we can complete treatment and get them to where they need to be health-wise. I find it fascinating that in correctional facilities in the United States, treatment did not start being offered in our institutions until the 1950s, when streptomycin was discovered in 1943. So we are a bit behind the curve by almost a decade for treating these folks. And then you hate to say it, but oftentimes for change to happen, something bad has to happen. And Officer Peter Pitosino, sorry to butcher his name, is a prime example of that. So this was a correction officer in New York City back in the 90s after the HIV/AIDS boom that happened, died of multi-drug resistant TB. His case kind of made a spotlight on TB and brought more attention to it kind of woke people up a little bit that, hey, we still need to be treating and testing and monitoring these people. They lost an officer, and there were several other of the healthcare members at that site that also contracted TB. So you hate to say it, but sometimes it does take something bad happening before change is made. Let's see. So in treating and identifying TB in our incarcerated population, I have noticed in my practice that when we have caught latent TB cases and I speak with these patients, there's a common theme of shame. And that's across all races, ages, walks of life, which I think speaks volumes to the stigma that comes with this infection and the misinformation that that the masses have. So when they test positive, until we prove that this is not an active case, they are isolated, just usually for a day. We have x-ray that comes on site 3 days a week. So whenever somebody is told that they are going to be isolated in a cell by themselves, there's usually two responses. One is, great, I'll get to have a great night's sleep. And the other one is, well, what is everybody else going to say? They're afraid that it's going to start the rumor mill. And some are also afraid that it is a punishment, because lock-ins are utilized as punishments within the correctional world, for on the side of corrections, not on the side of healthcare. Denial is seen oftentimes, which we'll get into a case presentation here shortly of an individual where I'll speak more to that. Reluctancy of treatment. These folks say they feel fine, which oftentimes you do with latent TB. You don't recall being sick. You're not right in that window where you're having the night sweats and the weight loss and feeling poorly. So you feel fine, and somebody sitting across the table from you telling you you need to take 4 months of an antibiotic and have lab work done. So there's a lot of resistance to getting treated for latent TB, as well as what I've seen in my practice. Complex mental and medical comorbidities. It's not just young, healthy individuals that come into the Justice Center. We have all walks of life, all backgrounds. I think the oldest patient that I've taken care of in here was 82 years old. Multiple disease processes, diabetes, hypertension, COPD, CHF, oftentimes endocarditis patients from IV substance use. So they're very complex, and you have to navigate that, in addition to the ailments that they didn't even know about until they came in to see us, and we provide them care that they have been lacking while they're in the community. So to give you guys a little bit of a window into how we're capturing these folks. On-site tuberculin skin tests within the last year, I ran a report, and it looks like we did approximately 3,444 implanted tuberculin skin tests. Now that number sounds pretty large, but in all reality, it's not near as large as the population that we see come and go from the Justice Center. On-site tuberculin skin test refusals within the last year were approximately 439 that are documented, because everybody has the right to refuse. It's like I tell my patients, you are the captain of your own ship. I am just here to give you the information so you can make informed decisions. I cannot force anything upon you. Wildly enough, this number, which was way larger than I even anticipated, intake screenings are something that happens for every individual that comes into the Justice Center that stays with us more than 24 hours. So the amount of intake screenings we completed within the last year was over 17,000. So our numbers of implanted tuberculin skin tests pale in comparison to that number. At first glance and at first thought, I thought, oh my gosh, we're failing here. But these are the folks that come in, stay for a night, and get released the very next morning. There's absolutely no way to capture them and even provide a tuberculin skin test, in addition to the refusals. So the number of 3,444 I will take, because those are the ones that stay, and those are the ones that agree to let us investigate and see what their status is. So I'm grateful for that. Couple of case presentations that I want to discuss to give you a glimpse into the treatment and decision to treat. This is the first one. There's two cases, 54-year-old African-American male with a positive tuberculin skin test, which was obtained for a detail. Now, a detail is something, depending on our patient's charges, that they can work while they are in the jail. You have to get approval based on your charge and screening done by intake. So sometimes it's incentive for people to go ahead and have that consent to the tuberculin skin test, because you cannot have a detail without consenting to that. So he had refused initially for the tuberculin skin test, and then had it done for a detail. His risk factors included multiple incarcerations, which is a risk factor in itself, that I learned more so recently at the TB summit that I attended. Periods of homelessness and substance abuse. This gentleman was very angry when I spoke to him about this. There was obviously some undiagnosed underlying mental health issues. He reports he had been positive for years and was told his chest x-ray is fine, and was never offered treatment, and had no idea what I was talking about, and that he didn't need it. Valid, because somebody could have told him that. There is a lot of misinformation out there that after the chest x-ray is completed and you're fine, nothing else is needed, and that is not true. He denied recent or previous symptoms, which he, on the questionnaire that we all have seen as healthcare providers, everything was a no. So it wasn't even triggered for us to pursue anything with him until he requested this detail. Let's see. Current chest x-ray was negative for active TB, which he kept repeating that his chest x-ray was fine and that he didn't need anything. So just re-educated. It was difficult to obtain more of a history with him in regards to symptoms, or if he ever had felt sick in the past, ever had the weight loss, the night sweats, productive cough or non-productive cough sometimes, which is interesting enough to see. And he was very reluctant to talk, which is a testament to his previous interactions with the healthcare system. Inconsistent compliance, even with DOT. So DOT is directly observed treatment, which is thought to be the best way to treat latent TB and active TB, even back when treatment first came about, which is why I believe my coworkers' parents were forced into the sanatorium, because that was the belief that directly observed treatment was the kind of gold standard and the best way to ensure that treatment was completed. Now, while I agree somewhat with that, I think that it takes away patients' self-capability of taking care of their own medication regimen, and it's kind of a slight. We have to have trust in our patients to want to do what's best for them, but they can only do what's best for them when they have all of the information. So education is huge, especially in regards to developing resistance to these antibiotics, and then it becoming a big problem if the tuberculosis reactivates later down the road for them. So that's something that I always enforce and reinforce and re-educate, that once we start this, completion is needed so that it doesn't cause problems down the road. So our next individual for a case presentation was a 41-year-old African-American male, positive quantiferin gold on a court-ordered lab, negative on-site, interestingly enough, tuberculin skin test. So a court-ordered lab, when individuals are involved in assault cases, violent, sexual, there's close interaction with the victim and the perpetrator, the court is able to order for infectious disease labs to be obtained. That was this individual's specific case. So kind of an odd, not odd, but it was interesting because we had no idea until these were faxed over from the lab that came from the court to give us these. And in my TB summit that I attended at the health department last year, I always thought that, well, if your skin test was negative, you don't need to go any further. And if your skin test didn't have induration, but you had some redness or maybe a small blister, it could have been an allergic reaction. And that is not the way that we need to handle tuberculin skin test. If there is any blistering and the induration guidelines are there, it most likely is not a allergic reaction. So it's not trying to disprove or prove one of your tests by ordering another. It was a coincidence that the court-ordered lab came through. We were unaware that it was obtained. So in interviewing this patient and getting more information, he had immigrated from Mali, West Africa, less than a decade ago. I believe it was 6 years ago, and had several incarcerations since coming here. So that puts him at very high risk for having encountered tuberculosis at some point. French was his primary language. However, you could communicate with basic English. And I'm a firm believer in always using an interpreter if English is not your primary language, because some things do get lost in translation. I was able to get more details from him while on the phone with the interpreter. He did have weight loss. When he immigrated, he said almost immediately within the 2 years that he immigrated, he had lost several clothes sizes. So he didn't weigh himself, but he needed to get smaller clothes. And then his weight had stabilized and stayed the same after his weight loss. He never regained the weight. Did have a positive history of night sweats, not current, but in the past. And then a prolonged cough that had resolved several years ago. But there were all the signs and symptoms that this gentleman had encountered tuberculosis at some point in his life. And I just wanted to point out that while we were figuring this out, his current chest x-ray was negative for active TB with the education presented to him. And he was very aware with what tuberculosis was. Again, the theme of shame hung his head when I told him that all information that we are being presented with does indicate that at some point he did come into contact with tuberculosis. He asked me how his family was going to take this information and was afraid to notify his family. So a lot of emotional support was given and needed, and a lot of information because unfortunately that stigma that comes with this, and from where he's from, which is known to be a high prevalence of tuberculosis. So this is just some research that I wanted to point out how many people currently fell ill. I know a slide previously, it's over 1 million died worldwide from tuberculosis, but estimated over 2.5 million fell ill with tuberculosis in the African region in 2021. So still very prevalent. We have hotspots for these places, obviously, but it's something to always be aware of, especially when you have folks that have immigrated from these hotspots. And then we talk about frequent incarcerations, where my specialty is. It's something that should definitely perk your ears up when you're interviewing these folks and talking to them about possible exposure and running through that list again. Because even though they might speak fluent English, there are still things lost in translation when English is not necessarily the primary language. Oh, and also, it's the 13th leading cause of death worldwide in the year 2020 to 2021. So for me, that is something that we need to not just be aware of, but always have sitting on the back burner, that this is still very relevant. And as healthcare providers, we need to do everything that we can for screening, treatment, and figuring out what these folks need. I want to do an honorable mention for the BCG vaccine. So this is not something that is given in the United States. It is in foreign countries to us. It is to help protect children from contracting tuberculosis. It does not offer long-term protection even into adolescence. The reason why I want to mention this is when somebody has had the BCG vaccine, they will oftentimes have a false positive tuberculin skin test. So it's important to be thorough in our interviewing and to know if somebody has had this. And if they have had this, that is when we are going to utilize quantiferin gold blood testing and chest x-rays. So just a BCG honorable mention. Do not forget to ask that when you are interviewing your patients. Now, here is a slide from Up to Date, one of my favorite references to use in my practice, and I'm sure a lot of you use this as well. Wonderful information always provided on here. It's a breakdown of the treatment options that we utilize for latent tuberculosis. The one that we use most frequently on site, of course, is rifampin. I do want to give an honorable mention, though, to Levaquin. I had a patient come in HIV positive with a respiratory infection and a positive TB skin test. Now, didn't have information with the chest x-ray, but I needed to still treat his respiratory infection. So word to the wise for prescribers, if you are concerned that there is possibly TB in the picture, do not choose Levaquin as your treatment for a upper respiratory lung infection. Because if it is active or even latent TB, you are going to ruin the chances for that to be possibly a treatment down the road for the tuberculosis, because it's not going to be long enough. And as we all know, when we stop antibiotics too soon, depending on the type of infection, that is how we develop resistance. So once again, be very careful in your patient population. If you suspect tuberculosis, rule out an active infection before you prescribe Levaquin. So a little clinical pearl for our prescribers. Now, I thought this was interesting, and especially for my patient population, in addition to public health in general. We are dealing with folks that are of lower socioeconomic status, and we have to take this into account when we are talking about healthcare and prescriptions and treatment. I just, for my own information, I wanted to take a glance at how costly this would be for folks that don't have insurance. And rifampin, 60 capsules, which is a 30-day prescription, is $267.70. So for the 4-month treatment course, you're looking at over $1,000 for this treatment. I don't know about you, but if I didn't have 2 pennies to rub together, I definitely couldn't afford $1,000 for my treatment. So it's something to just make a note of in your mind, who you are working with and who you are dealing with. These folks oftentimes need help getting on some kind of assistance. I always direct them to the lovely people at the health department. You guys have a great team. And what people don't realize is when you are incarcerated, you do not have health insurance. And when you get released, there is a time lapse for you to be able to re-register and get back on health insurance. And time lapse in regards to antibiotic treatment don't go together. They don't mix well. So it's something to be very aware of. Now, when they are in our care, it's like long-term care. We take over the cost to treat for their medications. So it's something that I always like to make sure of how long somebody's going to be with us, and if we're going to be able to complete this course, or if we aren't, and it still is best practice to go ahead and get it started if they have resources at home. So either a married partner that they can get on their insurance and continue this prescription, because we never dispense pills upon release. It is always handwritten prescriptions. So they do have to take it to a pharmacy and get it filled. So something to just always be aware of. And $1,000 is a lot of money for somebody that doesn't have any. So here is just a breakdown of references of where I got most of this information from. It was really fun to dive into the history and look back and see. I mean, this presentation could be broken down into multiple presentations with the things that we discussed. It's a fascinating topic and worthwhile for anybody if you are a lover of history, if you are just curious, especially about tuberculosis or any infection in general. Things that I had no idea were my eyes have been opened. So it was really fun to do this research. And I want to kind of wrap up this presentation and just ask the group, what does tuberculosis mean to you? I can honestly say, and I'm kind of ashamed to say, when I had quite a bit more ignorance about the topic, I didn't think about it. It was one of those things that was dramatized in period films where you have the weak woman laying in bed coughing up blood. It was the best reference that I ever had for tuberculosis. We didn't talk about it a lot in my undergrad or even in grad school because the common theme is it's a infection of the past, and that's just not true. So it's treatable and curable, and I think that it is extremely sad that if it's curable, we lost over 1 million souls in 2023 to this infection. So it means a lot to me now. And I once again thank the lovely folks at the health department for these summits and the information that's presented at these summits, because if I hadn't went that day, I would still be ignorant. So I'm so glad that I went. And I want to wrap up with, I always like to make references, the way that my brain works and why I think the way that I do. And for what tuberculosis means to me, I think of the famous quote, the infamous quote of the Japanese admiral of the Navy after Pearl Harbor was attacked. And he said, "I fear all we have done is to awaken a sleeping giant and fill him with a terrible resolve." That's how I feel about latent tuberculosis. It is a sleeping giant. And we never know what somebody is going to encounter down the road that has latent TB. If something as simple and as awful as malnutrition can reawaken this bacterial infection and kill its host, that's too much of a risk for me. Now, the numbers that I read, about 10 to 15% reactivate. I don't know how we can come to that conclusion when we never know when somebody is going to be diagnosed with a cancer or an autoimmune disease and be on biologics that suppress the immune system. So to me, it's too risky. And I don't want to ever encounter someone and let them pass me by and the sleeping giant reawakens later in life and they succumb to something that was treatable. So that is how I feel about it. And this is just an honorable mention and recommendation. If you like to listen to audiobooks, I do on the way into work and on the way home. John Green does an excellent historical review of tuberculosis and secondhand accounts of being in TB hospitals in, I believe it's Sierra Leone. So it's a great listen, a great read for all of our readers out there. And I think that that's the end of my presentation. It looks like we have maybe 5 more minutes if we want to open up to any questions.
Emily, I just want to thank you so much for a tremendous presentation. You really highlighted so many thoughts that aren't spoken to, aren't thought of. Even in my seat at Hamilton County in the TB control, this is something that, we'll say, yeah, we help the community, but you really see the community in a different area, in a different light, with similar stigma, but also your individuals, your patients go a little bit further in that stigma where they can't really escape room to room as to isolate, right? Our patients, they can go into a motel, they can go into their home. Yeah, sometimes they do experience stigma in their families and rejection. We've had that before for sure, but to not be able to remove themselves because they are in a holding, or they're in a, you know, a cell space where they can't avoid that, is tremendously depressing. And to see that, and see how passionate you all are in the Justice Center to make sure these people are paid attention to. You know, this is so very important for their health. This is healthcare. And that it's not just, you know, do this and do a X-ray and then pass it off and not investigate a little bit further. So what you're doing is tremendous work. So we really appreciate you.
Thank you so much. And what you guys are doing also, tremendous work. I can't tell you how many times I mention you to patients as a resource, and you guys are so knowledgeable, and an excellent, excellent thing that you're doing presenting these summits. So I'm very honored that you chose me to speak today.
Thank you. We appreciate that. You know, I thought it was really interesting about the high risks and social determinants of health that you brought up too, is that, you know, so many don't quite think of, you know, where did you come from? Who could you have encountered? For instance, your case study, your second case study, they're from, was it from Africa, from Ghana?
Mali.
Mali.
Mali,
And
West
so,
Africa.
yes. And so, you know, there are significant impacts in health that, you know, maybe this little blip on an X-ray isn't just, you know, a pulmonary nodule that someone else will have to take care of at a different time, but maybe something a little bit deeper if we were to get a TB, a quantiferon, you know, and like look, investigate a little bit harder. And, oh yeah, I've been having dramatic weight loss for some time. And people are like, oh, you know, you don't have enough money for food, or maybe you have diabetes, or there are, you know, other comorbidities that play a part in that, but nobody really thinks that that is a side effect of TB, you know, and so not to just mull over it, but yeah, I really appreciate it.
Absolutely. And the weight loss component it's difficult, because while it's one of the key components of tuberculosis, we talked about consumption and thysis, right? The wasting syndrome.
Yeah.
When you have somebody in front of you that is an IV drug user, possibly HIV positive, there's multiple reasons why they're losing weight, right? So making sure that you're being thorough is very important. And that's what we strive to do here at the Hamilton County Justice Center in the medical department.
Awesome. Does anyone have questions for Emily? I will stop chattering away here because, you know, I do, but go ahead and come off mute if you're, I hope I allowed that for this Zoom call. Or you could throw it in the chat. I'm looking there too. We have a lot of good kudos in here.
Emily, that was a fantastic presentation. A quick question for you in case you have this piece of information. Out of the many TSTs that you do in a year, what's the positivity rate? Has anyone ever estimated? Like, is it 5%, more than 5%, less than that?
So I wish that I had that number for you. Running reports was a new thing for me. And I really wanted that information. But unfortunately it's not set up in our electronic medical system to run a report for the positives. So I would have to go through and hand count each read, which I just didn't have time to do before this presentation. But
no, that's completely fine. Yeah, I was just
yeah, but it's valuable. It's valuable information, and if I get some time, I have no problem doing that, and would love to know the numbers for sure.
Thank you for your service and all the excellent work you do. Thank you so much, really.
Thank you to you guys as well.
Emily, I was kind of fangirling a moment because I actually am from New Jersey area. I went into the city to the Morgan Library, and Franz Kafka had an exhibit.
Okay.
The Czech author writer, and it was all about his life through tuberculosis and as an author and as a writer. And there's actually a really great book that many that he wrote, but one particular that I ended up grabbing for my two kiddos, which they're just going to be like, as when they get older and realize what the book's about, they're going to be like, my mom's such a nerd. But it's actually called Kafka and the Doll. and it's a children's book about him meeting, you know, a little girl in the park, and the little girl loses her doll, and you can see that he goes away for some time and he comes back and he looks more ragged. He looks like he's been really sick. And it's actually so interesting to know as an adult who knows about TB that they are portraying that he is sick with tuberculosis in this children's book, but not saying it out loud. So it's a really good thing. If anyone is interested, I'm sure, you know, booksellers have it. But it's called Kafka and the
Absolutely.
Doll, and it's really interesting.
Kafka and the Doll. I will have to read that.
Yeah, I'll share it when I go to post this. So I will say that I did record it. Sorry, I recorded a smidge late. As soon as I started talking, I'm like, you knew you forgot to do one thing. But we have recorded this whole thing. And the new thing that I have and worked with our comms here is that I am able to put this on YouTube. So we will have this presentation available for YouTube. Once I get that done, I will share that. I will be sharing, and if you don't mind, I'll go ahead and share my screen here to show that we do get, can you all see my screen okay?
Yes.
Okay, great. So Bon Secure Mercy Health.
Oh, we lost your audio.
Oh, darn it.
There you are.
Oh, good. Oh, you never know. Okay, am I still good?
Yes.
My connection is unstable. Thank you, Zoom. So I will share this basically, and you'll be able to sign in and get those credits tomorrow. Yep. So, and then let's see, I have one more. Of course, I'll send out my request for evaluation. This is just for us to evaluate how we're doing in the summit and hear back from you who have attended. So I will share that with a follow-up email as well. If any of you have questions for Emily, she is in, you know, I will make sure to send those to her. And if she'd like to provide her email, I can send that out too. That's up to Emily. But we will make sure we have all that. Anyone else, before I start to wrap it up here, anyone else have any further questions, comments?
So I just wanted to say I left my work email in the chat because I had to
Yeah.
sign in through my phone through a different email account. So if you could send my stuff, it's Brandy
Brandy,
McNamee.
gotcha.
Yeah, to that email.
Okay, I am copying and pasting it so I can keep that with me. I did see one question here. How many isolation rooms or areas does the Hamilton County Justice Center have?
Very good question. So there's a twofold response to that. We can isolate all over the jail for lots of things. It's just being in a cell by yourself. But for airborne isolation in particular, we have 2 isolation cells in our medical housing unit that have negative airflow. One in the female unit and one in the male.
Emily, were you there during time of COVID? Was that ever an issue where you had to isolate someone for a different respiratory illness at the same time as TB?
I was not here. I was in the long-term care sector during COVID, and I can attest to it was a terrible time. Again, there's a lot of misinformation out there about what happened during the pandemic, and it was the best way I can describe it would be difficult at best. There was not enough space, PPE, especially in our elderly population. So I can assume that here it was equally as difficult, but in long-term care, it was extremely difficult to isolate. And that kind of compares to here because you share rooms in long-term care, just like in here. Sometimes there's 2 people to a cell, and sometimes there's 4 people to a cell. So it just depends.
Thank you so much.
Mm-hmm.
That is all the questions. I'll go ahead and wrap that up there. Again, we appreciate you coming out tonight and listening in. Of course, credits are always a good draw in, but also, you know, this was such a tremendous presentation that highlighted so many wonderful things. So thank you, everybody.
Thank you, everyone, for coming. And once again, thank you to the Hamilton County Health Department. You guys are fantastic.
All right. Have a good night.
And you guys too.